Welcome to this high-yield explainer from the Anesthesia Learners Academy. If you're a PG resident prepping for your fellowship exams, you are in exactly the right place. Today, we're going to completely optimize your board prep by breaking down the highly tested, heavily detailed pre-operative preparation and guidelines. We're taking those massive, complex clinical standards and distilling them right down into the precise facts you absolutely need to know before your patients ever reach the operating room. Here's our roadmap for today's session. We'll be hitting NPO protocols, cardiovascular management, endocrine management, blood thinners and psychotropics, lifestyle and COVID-19 deferrals, and finally, day of surgery preparations. Let's just dive right in. Section 1. NPO protocols, the foundation. So the entire goal of pre-op fasting is pretty straightforward, right? It's to prevent aspiration. Under anesthesia, patients lose those protective airway reflexes, like coughing. And if there's anything sitting in the stomach, it can passively regurgitate right into the lungs, causing severe pneumonitis. Controlling exactly what and when they last ate is absolutely critical. You have got to memorize the progressive 2, 4, 6, and 8 hour rule. It's 2 hours for clear fluids, think water or black coffee without milk. 4 hours for breast milk, since that empties relatively quickly. 6 hours for formula feeds and light semi-solids, and finally 8 full hours for a fatty meal. Exams notoriously use mutton as the classic example of a fatty meal trap. Why does it take so agonizingly long? Well, heavy fats trigger the release of cholecystokinin, which profoundly delays gastric emptying. A patient who had a heavy dinner at midnight, they're still at a huge risk for aspiration early the next morning. Lock this timeline in.
Moving on to Section 2, cardiovascular management, the complex core.
Managing blood pressure and heart function perioperatively is always a delicate balancing act. You're trying to prevent acute cardiac events without causing dangerous drops in blood pressure under anesthetic agents. Now, exams love exceptions, so while you generally continue most antihypertensives, you absolutely must stop ACE inhibitors and ARBs 24 hours prior to surgery. Why? Because these drugs blunt the renin-angiotensin system. Combine that with the vasodilatory effects of general anesthesia, and your patient can develop a refractory vasoplegic syndrome. That is a profound treatment-resistant hypotension, and you do not want to be dealing with that. The same 24-hour stop rule applies to sildenafil for the exact same vasodilatory reason. On the flip side, always remember to continue beta blockers and thiazide diuretics on the day of surgery. Beta blockers protect the heart from surgical stress. Preventing rebound tachycardia is paramount here. And thiazides are kind of unique among diuretics. Unlike loop diuretics, which cause massive volume shifts, thiazides have a much lower risk of causing dangerous intraoperative fluid depletion. Keep them going.
Section 3. Endocrine management, glycemic control.
Stress hormones like cortisol and epinephrine run absolutely wild during the surgical response. This naturally causes blood glucose levels to aggressively fluctuate. Strict diabetes management is critical because well-controlled glucose dramatically cuts the risk of post-op surgical site infections. It's a real game changer for wound healing. The crucial distinction here is between the different classes of meds. You need to stop SGLT2 inhibitors a full 24 hours prior. Why? Because they carry a severe, highly tested risk of inducing euglycemic diabetic ketoacidosis when combined with fasting and surgical stress. Standard oral hypoglycemics, though, just hold those on the actual morning of the surgery. Insulin management is basically about avoiding two extremes. You don't want to stop it completely because an absolute lack of insulin drives the patient into standard DKA, but giving the full dose to a fasting patient risks profound hypoglycemia. The gold standard? Reduce long-acting basal insulin like Lantus or Levemir by exactly half on the morning of surgery. That provides just enough baseline coverage. Oh, and always advise patients to bring oral glucose gel to the pre-op area, just in case.
Now, what's incredibly highly tested regarding these clinical guidelines is the specific threshold for mixed insulins, like the 70-30 or 75-25 formulations. You only give half the prescribed dose on the morning of surgery if the patient's morning blood glucose is strictly greater than 200. Mixed insulin contains an intermediate-acting NPH component, which has a notoriously unpredictable peak time. If you give that to a fasting patient whose glucose is under 200, that NPH peak is going to hit exactly when they are deeply anesthetized on the table. That causes a masked, catastrophic hypoglycemic event that you won't easily detect until it's way too late. If their glucose is less than 200, you just hold the mixed insulin completely.
Section 4. Blood thinners and psychotropics.
Hemostasis is obviously a major physiological concern. Messing up antiplatelets and anticoagulants can lead to either catastrophic surgical hemorrhage or life-threatening postoperative clots. You need to lock these specific timelines into your visual memory because the exact stoppage times are pretty much guaranteed to show up on your fellowship exams. Clopidogrel and warfarin, Both stopped 5 days before. Ticagrelor is stopped 3 to 5 days prior. But notice how prasugrel is pushed way out to 7 to 10 days, and ticlopididine requires a full 10-day cessation. The pharmacology behind this is the difference between reversible and irreversible inhibition. Ticagrelor is reversible, so it washes out of the system in just a few days. Clopidogrel and prasugrel, however, irreversibly bind to the platelets. You literally have to wait for the patient's bone marrow to synthesize entirely new, uninhibited platelets before it's safe to cut, and that takes anywhere from 5 to 10 days, depending on the drug. While standard practice usually dictates stopping aspirin 72 hours before a procedure to minimize surgical field bleeding, you must memorize these 3 specific exceptions. Continuing aspirin here is absolutely life-saving. If the patient has had a recent MI, a recent stroke, or recent coronary stenting, you continue the aspirin. Stopping it in a patient with a fresh bare metal or drug-eluting stent practically invites acute stent thrombosis. Since surgery itself induces a massive prothrombotic inflammatory state, a clotted stent during a procedure is almost universally fatal. The risk of an acute cardiovascular event in these patients exponentially outweighs the annoyance of minor surgical oozing.
Looking at the psychotropics and neurodrugs, we see a massive contrast. You must keep those anti-epileptics going right up to the surgery. Anesthetic drugs and hyperventilation can easily lower the seizure threshold, so maintaining those drug levels is completely non-negotiable. But look at the discontinuation side over here. Lithium needs to be halted 24 to 48 hours early due to renal toxicity and the way it interacts with muscle relaxants. And the big one? Tricyclic antidepressants must be stopped a full 3 weeks before the surgery. Why 3 whole weeks? Because TCAs profoundly alter neurotransmitter reuptake. If they're still in the system, they can trigger vastly exaggerated, uncontrolled hypertensive responses when the anesthesiologist pushes indirect-acting vasopressors, like epinephrine, in the OR. It literally takes about 3 weeks for the catecholamine stores to replenish and those receptors to normalize back to baseline.
All right, Section 5, Lifestyle Factors and COVID-19 Deferrals.
Pre-op optimization isn't just about prescription pills. It's about looking at the patient's entire physiological state. Ideally, patients should quit smoking 6 to 8 weeks prior. That reduces airway reactivity and gets that mucociliary clearance working again. Here's a massive high-yield fact. High-dose estrogen and oral contraceptives and hormone replacement therapy severely spikes the synthesis of clotting factors in the liver. That dramatically increases the risk of post-op DVT, meaning they need a conservative 4 to 8 week cessation period. Herbal supplements, specifically the Gs like garlic, ginger, and ginseng, are potent, unrecognized platelet inhibitors. Stop them 7 days prior to avoid unexplained surgical bleeding. And for chronic alcohol users, you stop intake 24 hours prior, but you've got to be highly vigilant. Surgical stress can easily precipitate acute delirium tremens, so you must proactively manage their withdrawal with benzodiazepines, specifically Librium.
The new normal in board exams focuses heavily on post-COVID deferrals. This timeline cleanly maps out the elective surgery wait periods to make sure patients have recovered enough immunity and pulmonary reserve. If they just got a vaccine, defer for 2 weeks to avoid confusing vaccine-induced fevers with surgical infections. If they had mild COVID symptoms or an upper respiratory infection, defer for 4 weeks to let the airway hyperreactivity calm down. Heavily focus on this last one. If they had severe COVID-19 requiring an ICU admission, you must defer that elective surgery for a full 12 weeks. ICU-level COVID usually implies ARDS, acute respiratory distress syndrome. The lungs suffer massive alveolar damage and early fibrosis. General anesthesia requires positive pressure mechanical ventilation. If you tube and ventilate those stiff, recovering lungs too early, the risk of deadly barotrauma is exceptionally high. Give them a full 3 months to heal.
Section 6, Day of Surgery Preparations.
Okay, we've managed the weeks and days leading up, and now the patient is sitting right there in the pre-op holding area. Let's test your knowledge with a recent, highly tested question regarding surgical site prep that actually tripped up a ton of residents on a recent FMG exam. Think about the standard of care for a second. What's the right tool?
If you guessed clippers, you hit the nail right on the head. Hair removal should only be done on the exact day of surgery, right before the procedure, and traditional razors are completely avoided. Why? Because razors inevitably create invisible microabrasions right along the epidermal layer. These tiny cuts act as a perfect nutrient-rich breeding ground for endogenous skin flora like Staph aureus, which significantly spikes the risk of catastrophic surgical site infections. Clippers, on the other hand, just trim the hair right above the skin line, preserving that crucial epidermal barrier. Always select clippers as your correct exam answer.
Preparation for surgery isn't just about the operation itself. It's about meticulously optimizing the physiological terrain before the first incision is ever made. If this rapid-fire explainer sharpened your clinical edge today, please make sure to like, subscribe, and share the Anesthesia Learners Academy with your fellow PG residents to keep crushing those exams. But it leaves us with one final thought. As surgical techniques become increasingly non-invasive and highly targeted, do you think our strict, sweeping fasting protocols and lengthy deferral guidelines will eventually become a thing of the past? Until that day comes, trust your preparation and go ace that fellowship exam.